Event for 4 days, okay? And you come in on day shift. And they say, yeah, the patient's been on the vent for 4 days. They had pulmonary contusions, and they were in a car accident, pulmonary contusions, blunt chest trauma, and they're giving you a report. Here's the blood gas, blah, 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 blah. So what do you want to think about before deciding if your patient's ready to wean? What's the first thing you want to think about to decide if your patient's ready to wean?
Have they treated the pulmonary contusions?
Okay, so the reason the patient was intubated, has it been reversed? That's your number one thing you have to think about, okay? Is it fixed? If the patient had pneumonia, is the pneumonia getting better per x-ray, per secretions, right? Is the pneumonia getting better? Are the rib fractures healing? Is there no longer a flail? Okay, so all of these things we need to think about. So your patients had a mild pulmonary contusion but needed to be intubated. So how would you assess that to see if that's reversed? What might you look at for a pulmonary contusion?
X-rays.
Huh?
X-rays.
Yeah, so you'd look at your x-ray. Good. So your x-ray has improved from day one. Okay, there's an improvement. What else might you look at, Prince? Pulmonary contusion. So contusion is what? What's a contusion? Which you're going to cover tomorrow. It's bruising of the lung. So it's bleeding. There's blood. Bruising is blood in the tissue. So there's bleeding in the lung tissue.
So you would see their secretions, their CNS, if there's blood.
So you're looking for secretions, right? And what else could you do for assessing your patient? Basic, something very basic.
Oxygenation?
So you're gonna look at their ABG and make sure their ABG is adequate, their acid-base balance, and their oxygenation. So they had a contusion in the right lower lobe. How do you assess that it's getting better besides the x-ray?
Listen.
Freckles?
Auscultate.
So you're gonna auscultate, right? You're gonna palpate, right? To see if things have changed. So things have changed. So what kind of parameters would you like to see someone on if you're thinking about weaning and extubating? Okay, so say they were on pressure control AC, all right? Do we keep them on max support the whole time? Every day we keep them on max support?
Not if you're trying to wean.
And what do we do when we're thinking about weaning? What kind of trial do we do in the morning? We do an Spt Trial in the morning, right? But how about PEEP? Would you want them to be on high PEEPs, high FiO2s? So where would you, this is where I wanted your head to go. Where do you want your patient to be before you say, yes, I'm ready to do an Spt Trial? That's what you need to think about, okay? Because every day you come in, you have to assess if your patient's ready for an Spt Trial. We actually have a protocol at PG Hospital. You have to check it off every day. And if they meet that criteria, then they're ready for an Spt Trial, and you must do an Spt Trial, and it has to be done by 9 o'clock in the morning, every patient. Okay, so you come in, that's the first thing you're gonna do is assess. Is this patient ready to be weaned? Has the problem reversed? Are their blood gases adequate? What FiO2 would you like them underneath?
Less than 50.
Pardon me?
Less than 50.
Okay, how about PEEP?
8.
We never go less than 5, but you'd want it down to 5, normal, right?
Less than equal to, yeah.
Right, and they could be on for full support because we do that nowadays. We keep them on a rate, whatever rate they're on throughout their whole stay, and then we just do Spt trials in the morning. So we take them from full support down to an Spt trial. So for the patient to be ready to be weaned, we've said their disease process needs to be reversed. They need to have low FiO2s, low PEEPs, right? So we've checked off those boxes. What else do we need to have the patient, what else do we need to look at for the patient to be ready for an Spt trial?
If they're on paralytics or
neuromuscular paralytics. Right, right. I mean, they must be pretty serious if they're on neuromuscular paralytics, because we don't really use those anymore. Very rare do we use those. So they'd be critical if the patient was on a neuromuscular paralytic. But definitely you would not want to wean them if they were on a neuromuscular paralytic, because they wouldn't be able to breathe. What else?
The gag reflex.
Good. Gag reflex. How do you test for, is that what you said too? That's funny. Thanks. How do you test for a gag reflex? Where is your gag reflex?
Stick with two.
Where's your,
Or
it's in the back of your throat. It's in the pharynx, is your gag reflex. Where's your cough reflex?
James.
No.
carina.
Carina is your cough reflex. So whenever you're assessing neuro, you need to make sure you have a positive gag and a positive cough. And you write that. You're gonna say, when you're charting, this is especially important if your patient has a head injury or you're working up the patient for brain death, right? You're gonna say positive gag, right? Positive cough. That's important that you write that, because that lets people know that your patient's neurologically stimulated. So they have these receptors functioning. Okay, so good. So neurologically, we want to make sure our patient is what? This is all in this PowerPoint today. How do we want our patient?
Alert.
Obtunded?
No.
So alert. What do you want to make sure your patient's able to do if you're going to take them off the vent and pull the tube out? So you need to make sure they don't need that ventilator, right? What are the four things for needing mechanical ventilation?
Risk of aspiration.
Risk of aspiration. These are going to be asked of you over and over and over, especially in case presentations.
Need for oxygenation.
No.
No.
Ventilation.
Need for suctioning.
Suctioning, yeah.
What else? So need for mechanical ventilation, need for suction, or I said was one of them. Need for mechanical ventilation, need for suctioning, risk of aspiration. Risk of aspiration,
Or is that airway?
it's airway,
That's airway.
yeah. You tell me the last two,
The
'cause we just
hypoxia.
talked about them.
Yeah, the ventilatory failure.
Right, and impending.
And impending.
Ventilatory failure. So those are the four reasons that you have to rule out. Patient doesn't have any of these reasons. So I can get rid of my vent, but can I get rid of my tube? So you have to address both issues. What are the four things for an endotracheal tube?
Risk of aspiration.
Risk of aspiration,
Upper airway obstruction.
upper airway obstruction, secretions,
Suctioning.
what else?
And mechanical ventilation.
And need of mechanical ventilation, good. So those are the things you're looking at when you're deciding and no one's, you're doing the assessment. Nobody else is doing that, you are. Physician's not saying, well, they don't need this, this, and this, and this. You're doing that assessment by yourself. There's no other therapist there. So you need to know those. You see the importance of knowing both of those, right? You need to know that. So you say, okay, neurologically, we're gonna look at the systems. So neurologically, are they alert and oriented times 3, right? Do they have a cough and a gag when you suction them, right? When you suction them, do they cough? If you go near the carina, there's receptors all near the carina. You don't have to hit the carina and cause bleeding. You'll cause that carina to become mincemeat. We don't want that, right? So you go near the carina, it stimulates their cough, and they cough. So yeah, you have a positive cough. Just manipulating the ET tube whatsoever will cause them to gag, all right? So positive cough, positive gag, they're alert, they're oriented. Okay, so let's see, neurologically, we're good. So what other system would you want to look at? Respiratory, we already looked at, right? Respiratory, they look good. Cardiovascular, what do we want to look at cardiovascular? Stable blood pressure. Stable blood pressure. What's another thing you need to look at?
They're in the low dose of
Inotropes.
Inotropes and vasopressors. So if they're on vasopressors, period, do you think they're stable enough and you want that heart to work? No. Vasopressors means their heart is very unstable and they're vasodilated and it's taking medicine to pull blood to the core of their body. That does not say that that patient's stable. So you don't want the heart to work if the patient is unstable. Always think about that, the work of the heart, all right? So, all right, so we're looking at drugs. What else are you gonna look at, EKG-wise?
Oh, heart rate.
So you're gonna look at your heart rate,
Arrhythmias.
okay? You want your heart rate in a normal place, good. What about the EKG strap?
You mean the QRS,
Yeah.
T waves?
Yeah.
Make sure
So
they're
you've learned
regular.
about arrhythmias,
Mhm.
dysrhythmias, right? So you don't wanna have any PVCs. Do you know what PVCs, come from? They're the ventricle, right?
Contractions,
They're
yeah.
premature ventricular contractions. They come from hypoxemia. The heart's not getting enough oxygen, all right? So the coronary arteries, for whatever reason, they're not giving enough oxygen to the heart. All right, so we wouldn't want the heart working if you see multiple PVCs. You have bigeminy, which is every other. You have trigeminy, which is every third PVCs. That's saying that your ventricles are irritated or not getting hypoxemia or not getting enough oxygen. The answer to always to PVCs is oxygen. Give oxygen, okay?
So I have a question about that.
Uh-huh.
So if they do have PVCs, it would not necessarily show on the PaO2.
No, the
Because
PVCs are
it's-
gonna show on the, no, well, you're gonna see the PVCs on the rhythm strip,
Mm-hmm.
right? But what I'm saying, if they're having, if you're seeing multiple PVCs, and I don't just mean one, but if you're seeing frequent PVCs on your EKG, can you think about weaning your patient?
No.
No, you can't. Your heart is irritated. It needs that oxygen. It doesn't need to work. You can see it's already irritated by your rhythm, all right? So we would not want to wean if we had frequent PVCs, right? If you're on inotropes, high dose inotropes, or vasopressors, even low dose vasopressors, you don't want to think about weaning. What else about drugs? What kind of drugs do you want to not have your patient on if you're weaning?
Did we say sedatives and paramedics?
Premature ventricular contraction. Premature ventricular contraction, PVCs. They're irregular rhythm of the ventricle. The ventricle is not pumping efficiently. So you know what V-Tach looks like? You guys know V-Tach and V-Fib, right?
Oh, yeah.
Ventricular tachycardia. So a PVC, so let me show, so V-Tach, see if this looks familiar to you. Does that look familiar to you? That's V-Tach. Each one of these is a PVC. So it's not, the ventricle is not pumping out blood during that contraction. The ventricle is just doing crazy stuff. So there's no blood flow being pumped out during that contraction, all right? So if you have multiple, maybe you have a normal QRS, but then you have a PVC, and you could have every other beat be a PVC. That's called bigeminy, or every third beat could be a PVC. That's called trigeminy, okay? If you continue to have them, you will go into V-Tach, okay? V-Tach, you could have pulse, and you're gonna learn this in trends, but you could have pulse V-Tach, V-Tach with a pulse, or pulseless V-Tach, where you have to defibrillate, okay? So, and then this one here, okay, this is more V-Fib, okay? V-Fib. So this kind of looks like a slinky, and this is like a slinky pulled apart, all right? This probably is not going to be as big, but it's just a little bit more regular. It's a little bit more erratic, is V-Fib. Both are shockable rhythms that you learn about in trends. So my point is you need to look at your cardiovascular system. Make sure they're off their cardiovascular drugs or on low doses. Make sure you're looking at your EKG rhythm strip, right? You want to make sure they're not having irregular rhythms. Their heart has a stable QRS, PQRS, PQRS, stable. Okay, that tells us something about the patient. right? We don't want the patient's heart working if the patient is unstable, right? If the patient's having angina, right? We've always said that on the floors. Patient's having angina, do you take away the oxygen? No, because the heart is irritated. That's why patient's having angina. You need to give the heart the oxygen that it needs. Oxygen vasodilates coronary arteries. Okay, oxygen vasodilates coronary arteries, so you give the oxygen. Okay, so what other drugs would you want to see your patient off before you decide to wean?
Did we say sedatives and paralytics?
You said paralytics, I didn't hear sedatives. Okay,
It's sedatives, not sedatives, right?
sedatives, yeah, that's
Okay.
okay, it's sedatives. So what kind of sedatives would you see your patient on? Could you see your patient on?
I think morphine is one, right?
Morphine is not a sedative, that's a narcotic.
Narcotic, okay.
But high dose morphine could depress the respiratory drive, right?
Raw.
That's why people OD out on the streets. They do high dose morphine, or they do fentanyl. Fentanyl's what's killing everybody out here nowadays. Okay, carfentanil is dangerous to healthcare workers. That's a potent narcotic that is meant for like large animals, elephants, not for us. And it's on the streets now. So that even touching it, even if you touch their clothes and it's on them, it's killing healthcare workers. So that's something on the streets that's very dangerous. That's you gotta be careful with. Yeah, it is crazy. So fentanyl is 1,000 times more potent than morphine. Carfentanil is like, I don't even remember what they said, but 10,000 times more potent than fentanyl. So it's deadly to even touch. It'll get in your skin. So they have to gown up before they get patients. That's why everybody's dying around the country. But, okay, so we don't want our patients on high dose pain meds, right? And we don't want them on sedatives. What other kind of sedatives do you think you might see your patient on? Sedatives.
I think you just said, like, is rocuronium like a sedative?
Rocuronium is a neuromuscular blocker.
Oh.
Pancuronium, rocuronium, those are neuromuscular blockers. So what about the drug that Michael Jackson was on?
What do you call it? It's just
Mother's milk. We call that Propofol.
Propofol.
Okay, so that's the drug, that's really an anesthetic. It's not even a sedative, it's an anesthetic. And Propofol used to only be used in the OR, and now it's commonly used in the ICUs. All right, so, that's definitely gonna depress the respiratory drive, so you wanna make sure that they're not on Propofol. They're not on high dose of anything, okay? Even Ativan, any kind of sedative, anxiolytic, those are anxiolytics. They block, what's lytic mean? Block. Anxious is anxious, anxiety. So an anxiolytic is gonna block anxiety. That's a sedative. All right, so you wanna make sure they're not on any high dose of anything, Ativan or anything like that. All right, so, and when you think about so you've decided, okay, neuro-wise, we're good, they're off sedation, they're alert, they're awake. Cardiovascular-wise, oh, they look stable. Their heart rate looks good, their rhythm looks good. They're not on any cardiac drugs, so they've stabilized. Respiratory-wise, well, we've been doing that. We've been looking at x-rays every day. We're looking at ABGs maybe every day, depending if your hospital has Untitled CO2s or not. Ours does not, so we do ABGs every day. So respiratory-wise, you're already looking at all that, right? So you've checked off all the boxes and you say, okay, yeah, my patient qualifies to have an Spt trial. So how do you do an Spt trial?
CPAP.
For 3 minutes to get the RISB first.
Okay, so CPAP for 3 minutes to get the RISB?
Mm-hmm.
Okay, and how do you calculate the RISB?
Respiratory rate divided by the tidal volume.
In liters. Don't forget that. In liters. In liters. In liters. Yes, don't forget that. So you get your RISB, and what did you guys measure your RISBs at? What do you think normal RISBs are?
Less than 100.
Less than-
What was your RISB? Not 99. Huh?
46.
Yeah, it was around in the 40s, normal. It's just so you know what normal is, okay? And what do you want to have a RISB under? 105, specifically, 105. Good. So you did that for 3 minutes, and let me tell you, if your patient, if your patient is like borderline, they will tell you within those first 3 minutes whether they're gonna fly or not, right? Something else I forgot to tell you guys is you want to look at fluid balance, and all this is on the PowerPoint, but you want to look at fluid balance, okay? If you have a positive fluid, so what I mean by fluid balance is you get IVs all day long, right? So you're getting fluid pumped into you all day long. The nurse measures how much fluid is going in you, okay? How much urine you're putting out is how much they need to balance each other out. What goes in should come out. So they should balance each other out. If your kidneys aren't functioning very well for whatever reason, then you could end up having more fluid going in than coming out, okay? If you have more fluid going in, do you think your lungs could be wet? And that's the term we use in the hospital. They could be wet. You could see that on x-ray. You could have bilateral infiltrates, okay? If they have a positive balance. So you're always gonna look at the fluid balance before you decide, can this patient do an SPT trial? Okay, so we've looked at every system, okay? The renal system. Do they have a positive balance? Well, they were fluid resuscitated in the ED. They had 10 liters given, where a patient yesterday had 10 liters given, okay? 1 liter out. So how many liters positive am I? 9 liters positive. So when you are coding, you get fluid resuscitated, all right? That's how you get resuscitated. So do you think your lungs like that 2 days later? Your lungs are flooded. Your lungs don't like it. So I always say, my little thing is you have to be dry to fly, all right? So you can't have 9 liters positive and think you're gonna do an SBT trial and pass. It's not gonna happen. Patient's gonna have to be diuresed and dry that patient out before you're gonna be able to wean that patient, okay? So that's another important thing is the renal system. All right, so you've looked at all your systems. And if your patient is borderline, you do that first 3 minutes, they will definitely let you know that they're not ready. They'll immediately, if you take them off that positive pressure or their ventilation, because you're gonna leave them on your CPAP at 5, then they'll let you know within the first 3 minutes. So then what do you do if they tolerate the first 3 minutes and you've done a RISB and it's under 105?
You do it once in 24 hours for 30 to 120 minutes.
30 to 120 minutes, good. So what are you looking for? What kind of deleterious effects are you looking for? Which means negative side effects, deleterious side effects.
They're being fatigued.
Pardon me?
Fatigue.
If they're fatigued, so if the respiratory rate goes above what?
35.
35, good. What else are you gonna look at?
Hemodynamically stability.
Okay, tell me about specifically, how about the heart rate? If the heart rate goes to what? Would you expect it to go up a little bit? Yeah, you would expect it to go up a little bit. When do we say, okay, the heart rate's going up too much, we have to put him back on the vent? When do we stop this SBT trial?
More than 20, I guess.
What does it say on your PowerPoint?
Yeah, greater than-
More than 20, okay? So if it goes up by 10, you know they're working a little bit, so that's okay, it's expected. It's when you go past that expected parameter that you need to put them back on their, whatever settings they were on prior. So how about blood pressure?
Yes. If you
Blood pressure
exceed more than.
above what?
As well.
10 to 15, I think. 10 to 15 is.
So they could be hypotensive or they could get too hypertensive, okay? I think it's like 140. They start really working and their pressure's gonna skyrocket. All right, so you wanna look at all those signs. How about SATs? Where would you like to see your SATs?
90. that I also picked.
What does it say in your PowerPoint, Prince? Does it say anything about SATs?
Is greater than 90 plus.
So say that again, Wyatt?
It says that the deleterious change of less than 90%.
Okay, so all that sounds great, right? But if you have, let's say you have a 25-year-old who was gunshot wound, and you want to wean him and extubate him, where would you like to see a young person sat, honestly, when you're trying to extubate?
Greater than 90.
95. No, they're healthy otherwise, you know? So it's all relative. Somebody that's older, they don't have high oxygen saturations normally. So you want to take them back to their baseline. You want them at their baseline. So you want to keep, if I had a 18-year-old, I don't want their sat at 90, right? If I'm thinking about extubating them, because they're young people, they have normal parameters. So if I'm thinking about extubating them, you know, hopefully their oxygenation is a little bit better than that. But that's textbook. So clinically, you're gonna look at different, right? Somebody who's, you know, who has CHF and is 88 years old, yeah, if their stat's 90, I'm okay with that. You know, so it's all relative to the patient, to the individual.